Good afternoon, should I say, good morning and good evening from wherever you are joining us from in the part of the world. Thank you so much for being with us here. My name is Damaris Choti. I'm the coordinator of the student and alumni programs at the African Studies Center here at Michigan State University. And so I have the pleasure to welcome you all to our African Tea Time event today. And if you received the flyer, the discussion is going to be centered on the health systems and services in the Democratic Republic of Congo. And for that, I want to really say that we're very privileged to have speakers here today who have done research in this area. And that research is what they're going to share with us today in this discussion. And both of our speakers are from Tulane University in Louisiana, and we're very grateful really for the connections and the networks that we have with various institutions locally and internationally. And this has been made possible through our alumni and colleagues from all around the world, basically. So our first presenter will be Dr. Janna Wizneski. Did I butcher your last name? Is it Wizneski?
No, it's pretty close. It's Wisniewski, but not bad.
Wisniewski? See, I thought it's, yeah, Wisniewski. I'll try next time. So, Dr. Oh my gosh. Give me a second, please. Sorry, so then I was saying Dr. Wisniewski is a research assistant professor in School of Public Health and Tropical Medicine in Tulane University. And the title of our talk is going to be Measuring and Improving the Quality of Medical Care in the Democratic Republic of Congo. As I've said, she will be our first presenter. And then after that, we will hear from Francine Woods. And Francine is a doctoral candidate, School of Public Health as well, Health and Tropical Medicine, Tulane University as well. And the topic of our discussion is going to be insights to male involvement in maternal and child health, in Kinshasa, DRC. So at this time, I'd like to ask you to welcome me in join me in welcoming our presenters. And we are pleased to have everyone that has come to attend the event. And after after the first presentation, we're going to have a discussion on the top. And then after that, we'll go to the second presentation, have a discussion as well. And then we can close the discussion. So at this point, I want to give it to Dr. Wisniewski to take us through the talk, the first part of the talk. Thank you so much.
Thank you so much. I'm delighted to be here. I really appreciate the invitation. I'm actually an alumni of Michigan State. I got my bachelor's degree there in linguistics and I had an African studies specialization and studied Swahili with Professor Ngonyani. So it's really nice to be at least virtually coming home. And lots of pressure knowing that some of you are staying up really late to watch my talk. So hopefully it's interesting enough for you. And before I get started, it would be helpful to know, is anyone on the call from the DRC or has anyone worked in the DRC? No, I don't see any Congolese names. And is anyone working in healthcare at all? I know we have one epidemiologist, and does anyone else have health or public health experience?
Yeah, so I'm a PhD student in epidemiology, so not yet an epidemiologist, but yeah.
Okay, sounds good. So I will try to go over some basic concepts if needed, but please stop me if you need anything explained. I'm kind of used to presenting to public health audiences, so I'll do my best though. All right, so today I'm going to be talking about measuring and improving the quality of medical care in the DRC. In my agenda, I'll start out with a brief overview of the context in the Democratic Republic of Congo and show you how their health system is currently designed. I'll talk in general about how we define clinical service quality. And then I'm going to go through some of the ways that we are measuring clinical quality in the DRC now with a focus on what's called clinical vignettes. And then we'll talk about some strategies for improving quality with a focus on community scorecards. And then I'll go over some other ways. These are the two that I'm focused on, but I'll talk briefly about some other strategies that we have both for measuring and improving. You may be wondering why we have two researchers on different topics from Tulane who both work in the DRC. And our School of Public Health has a really long history of working in that country. We've been there since the 70s, doing different kinds of programming and research. And so we have a strong partnership with the Kinshasa School of Public Health, actually having helped start that school in the mid 80s. And so in the picture on the left, you can see the man in the brown suit was the first doctoral student from the Congo who came and traded to Tulane, and he later went on to be the dean of the school. It's Professor Lusamba. So we do a lot of work closely with them in research, programming, training, advocacy. There are strong partners there, and it's really enabled us to do some interesting work in that country. We have work in a couple of different topics, all related to health. I have them listed here. I primarily work on health system strengthening, so that's what I'll be talking about today. Francine works in reproductive health and family planning and maternal health, so she's going to be talking about some of those topics. We've also done research on nutrition, food security and resilience, and Tulane is part of a consortium with a Fogarty training program. So if anyone's ever interested in participating in that, we send scholars to the DRC, and then we also bring scholars from the DRC over here. A little bit of history. I'm sure you're all at least lightly aware of the history of the DRC, but I wanted to bring in some context that affects the health system and the way that health services are delivered in the country. So one thing to know right off the bat, which make things challenging, is the country is huge and the capital is very remote from most of the rest of the country. You can see Kinshasa there on the west side on that little peninsula, and then it's, you know, the bigger cities of Kisangani and Goma and Bujimai and Lubumbashi are very far away. And so managing a health system from sort of the other side of the country can make things really difficult, and especially in a place with sort of weak infrastructure. But Congo, as you know, was colonized by the Belgians and then received its independence. It has vast wealth from natural resources, much of which does not benefit the population because of corruption and exploitation by other countries. It has a long history of war and instability, 2 civil wars, and then ongoing conflict, especially in the east. So that would be up in the Kivus, mostly in Ituri, over on the northeastern side of the country is just chronically insecure, which also affects health service delivery. Because of the wars and instability, the country has suffered from ongoing brain drain of skilled professionals, either leaving the country to work somewhere else or leaving the public system to go work for NGOs, the World Health Organization, other organizations like that who pay better than the public system in the country. The country has had several presidents, but there's only considered one sort of democratic, peaceful transfer of power, which is the most recent one. So Tshisekedi is the president now, and things have been relatively stable since he took power, but it has disrupted things over time. And lastly, the country went through a few years ago, I think it was 2015, something called decoupage, where the original, or I guess not original, but the provinces that they had were cut up into many more provinces. And so I don't remember the exact numbers, but it was like something like 9 or 11 before, and now there's 20 something. You can see the current provinces here. And the way that's affected the health system is that each one of these provinces then needed to have its own provincial level health system, and some of them had nothing before. So they've been working hard to stand up a provincial health office and get their systems in place, get skilled, trained people in the positions within those provinces. And so that's been sometimes a bit rocky for the newer provinces who didn't have that infrastructure in place. Health in the DRC is comparatively quite poor, compared to other countries. There are 4 sort of big areas that we focus on. So maternal mortality is a huge problem, often due to eclampsia or hemorrhage. You can see the usual child illnesses here, lots of malaria, some vaccine preventable diseases, malnutrition is always a struggle. They do have several problematic infectious diseases. There's tuberculosis, cholera. Of course, DRC has periodic Ebola outbreaks. What's not on this list, interestingly, is HIV. While there is certainly HIV in the DRC, it has not been quite as bad as it has in other countries in Southern, Eastern, even Western Africa. They've been a bit more insulated from the HIV pandemic. And COVID as well. While there are, certainly COVID cases in the DRC, again, they haven't been as hard hit as even other regions of Africa for reasons that are not completely clear. And then violence and injury are also a struggle. So armed conflict, sexual and gender-based violence, and rape as a weapon of war, even traffic and work-related accidents are the types of things that the health system is dealing with, as well as your usual, chronic diseases, needs for primary care, and that sort of thing. On the positive side, the DRC does have some real strengths in their health system. They have an excellent outbreak monitoring and response system. This is largely because they are the country with the largest number of or most frequent Ebola outbreaks. And so they've really stood up a good system by which those outbreaks are reported quickly and dealt with swiftly. And so for the most part, they haven't spread like they have in other countries. And so they're good at that, and that makes them good at other types of outbreaks as well. So monitoring for measles, even COVID and those sorts of things, they're very, very good at that. They also have a really well-developed community health system. So systems of community health committees and community health workers, and even community health outposts far away in more remote areas that can kind of do basic services. Look for people who are sick or malnourished and refer them in. That system works quite well in a lot of places. They have a national health information system, which was stood up in 2014 and is now functioning to the point where the data is usable. The data is relatively trustworthy and is being used for making decisions at national and provincial levels, which is great. The DRC has a long history of well-trained physicians, particularly in the 80s and 90s. They had very good medical schools and very skilled clinicians. And lastly, the National School of Public Health is a huge asset. It trains a lot of the people who go out and work at the provincial level or at the health zone level, doing public health programming and that sort of thing. This map shows the organization of the health system. This may be familiar to a lot of you. It's similar to other countries in Africa, but they have a health zone model. A health zone is very similar to a district in some places. Basically, you have a health zone, and then it's divided into health areas based on population, not on geographic size. So some are quite huge, some are quite small. Within the health areas, there are health centers. The health center may serve several villages, and then each health zone is supposed to have one hospital that everybody's referring to. And the health zones make up the province, and then the province answers up to the Ministry of Health. So it's a very, on paper, a very organized system and a very publicly government-run system. There are private facilities, obviously, but in theory, the governmental system is supposed to be able to cover everybody. All right, so let's talk about quality a bit. This is a graph showing, or a chart showing the World Health Organization's building blocks of health systems. So it's basically showing all the pieces that make up a health system, regardless of where it is, DRC, Ghana, United States, Russia, wherever, they all have these pieces and they're all working toward these goals. So access, coverage, quality, and safety, leading to improved health, responsiveness, risk protection, and improved efficiency. And so one of my big focuses is on this quality piece and how these different building blocks interact and can be strengthened to improve the quality of the services that are delivered. So that's kind of where I'm focused. Quality is maybe more complicated than you might think at first blush. We talk about quality having 6 different dimensions, which I listed here. And when I first started thinking about quality, I thought, well, yeah, it means that you got better, right? If you got quality care, then you recovered, but that's a little too simplistic. And so we talk about it in these ways. First is promoting patient safety. So preventing medical errors, making sure that, it's kind of that first do no harm principle, making sure that you don't make things worse for a patient, you don't do the wrong thing. The second aspect is timeliness. So reducing waits and delays. This is important for health reasons. Clearly, you don't want people get worse as they wait. It's also important for psychological reasons. As you're suffering, as you're stressed out, that's not good. And then also for just economic reasons, the longer you wait for care, the less you might be able to work or take care of your family or do other activities. So timeliness is something that we look at as an aspect of quality. Effectiveness, pretty intuitive. We want to provide services that are based on evidence and avoid anything that's not likely to provide a benefit. So make sure we're doing things that work. Efficiency is important everywhere, but maybe particularly in a place like the DRC, we don't want to waste any resources. So physical resources, time, energy, all those sorts of things, because we are resource limited. Equitability is an aspect of quality. So we don't want care that varies in quality due to a person's characteristics. So we don't want males to get better care than females, or one ethnic group prioritized over another, or even differences by locations, urban, rural, or income, anything like that. Like the goal, the idea is that everyone is getting equitable care, no matter who they are or where they live. And lastly, patient-centeredness. So this is care that's reflective of patients' values, needs, and preferences. Has to do with cultural competence and things like that. Is considered a component of quality. And so the goals of healthcare, what we're working for in providing this quality care are 4 things. We want to prevent disease and injury from happening. We want to cure disease and injury when it does happen. When we can't cure it, we want to alleviate suffering. And just in general, we want to prolong life. So the quality concerns that we're worried about are providing too much care, providing too little care, or providing the wrong care. And then specifically the types of things that we look at in quality are can be like malicious acts. So this could be criminals, people drunk at work, people pretending to be physicians, those sorts of things. It could be negligence, not doing not doing what you should. It can be errors, so an overdose or prescribing the wrong treatment. But we also even talk about environmental hazards. So will you pick up an infection at the hospital? Might you fall down? Is it unclean? Is it an unsafe environment? That is a concern when we're talking about quality. And then operational errors. So are the waits too long? Is the computer system down? Things like that. Is there electricity? These are all things that we're concerned about. So quality is a big old mess. There's a lot in it, and a lot of things can go wrong, and there are a lot of different interventions that we can use to make things go right. So this is kind of where I live. This is what I like to study. So there's this old adage. I couldn't find who originally said this, but the old adage is, if you can't measure it, you can't manage it. So in quality, we're first concerned with just assessing the level of quality that's being delivered, and then we can move on to trying to improve it or trying to manage it. My first job out of grad school was working in a hospital in the United States, and I was working in quality management, and we had sort of this set of tools here in the US for measuring and managing quality. We have electronic medical records, and so a hospital can, with a click of a couple of keys, run the data on the quality of care that's being administered in their hospital. Interestingly, in the US, these medical records don't talk to each other typically among different facilities. So if you go to Sparrow and Lansing and get some scans run, and then you come down to New Orleans and you go to Tulane, there's no connection between those records. But at least within facilities, we have them. There's also a lot of government surveillance data. There are licensing processes. So providers and facilities have to meet certain standards and apply to have and keep their license. There's a medical malpractice system by which patients can sue providers if they feel that things have gone wrong. There's accreditation for facilities where they have to have certain quality processes in place in order to be accredited and paid. And then there are ongoing national patient satisfaction surveys. So these are the kind of things we use here in the US, and kind of the tools that I had in my toolbox when I started working in the DRC. But in the DRC, we really have one of those things, largely across the country. There is good government surveillance data, but that's kind of it in terms of what we might use here in the US. And so I think when we started working on this with the Kinshasa School of Public Health, the thought was not to just try and replicate what's done in other countries. First off, the US does not have a model health system and should maybe not be replicated anywhere. But the idea was to pick pieces from other countries that might work well, and also just sort of indigenously come up with ways of measuring and assessing quality that worked in the DRC, agnostic of what happens everywhere else. And so that's been pretty fascinating as we've worked through that. So I'm going to go through one method that we've recently used to assess clinical quality, and this is called a clinical vignette. If anyone has trained as a physician or a nurse, you may be really familiar with these because it's something that they use in in medical nursing school. But we wanted to use these as a way to assess, to start to assess providers' knowledge, if they knew what to do, how to handle certain types of patients, and also how they might treat them, what questions they might ask, sort of that bedside manner thing. So we did a survey of hospitals and health centers at 2 points in time, at 2019 and 2021. And we interviewed health workers in these facilities. And so we asked them, do you regularly provide XYZ services? So like antenatal care, child health, family planning. And if they said yes, we gave them a vignette related to that topic. So you can see the reason for the visit of the vignette and then the diagnosis associated with it. So for example, in 2019, people who said that they provided antenatal care got a vignette of a patient coming in for her first ANC visit, and the diagnosis that the person had was preeclampsia, or high blood pressure during pregnancy. So we did these at baseline and midline. At midline, we added a new one for COVID-19 because COVID, obviously had started the year before, and we were interested in seeing how the providers would handle them. Oops, sorry. So this is how the vignette works. I'll show you the family planning one, which we did the same vignette at both points in time. And so the very first information we gave them was a 22-year-old woman comes to the clinic on her own. She tells you that she's interested in using contraceptives. What questions do you ask her? And then we would record what questions the clinician said they would ask her. Maybe her occupation, or does she have any children, or something about her health. We recorded all of that. And then after that, we told them, you learn that she's never used a contraceptive method aside from the occasional use of condoms. She has no children, some health stuff, and then she's currently married but having sex and would like to delay having children for another 3 years. And then the question is, do you counsel her in choosing a method? Assume you have methods in stock. And so they would say, yes, I would give her a method, or no, I wouldn't. And then we move on. If they said no, we said, why don't you counsel her? What are the reasons? And we'd write those down. And then for the people who said that they would give her, a family planning method, she tells you she does not want anyone to know and asks you to keep it confidential. What do you do? And then we get their reactions to that request. So the standard of care in the DRC is that if a woman comes in requesting a contraception, she should be given contraception unless there's a medical reason why she can't have it. But we found among the health workers who provide these services, only 42% said they would prescribe a method. The rest of them would refuse this woman. And then when we asked her why, these are the reasons they gave. So most frequently it's because she's married, she can't have it. And then because she has no children and because her husband isn't there. We did some additional analysis to look at what mattered in the decision to prescribe. And we found that being young or being in the woman's age bracket meant that they were more likely to give her family planning. Being a physician or a midwife, having had training on family planning, gender or sexual and gender-based violence, being satisfied in their job, some of their attitudes, and what province they were in mattered. We saw a lot of provincial differences. So the takeaway from this is that the things that matter are things that are actionable for the most part. Like programs or the government can do more training, they can help improve job satisfaction. The things that didn't matter were things that are not actionable sometimes, like marital status or the numbers of children. That's not something that a program or a government could really impact. So that was kind of encouraging that there seems to be some work that can be done. So the implications of this, and I actually got back Sunday from presenting this in the DRC to the government and USAID and other programs. And so what we were able to show them from this assessment is that from other data, we know that family planning services are increasing. More health facilities are offering them. Sorry, did someone say something? No, okay. But these vignettes were able to show that the quality or their adherence to guidelines is probably not where they'd like it to be. So having a service in place doesn't mean that everyone's getting access to them. And so then we suggested training on gender issues and family planning could help people be more compliant with the treatment guidelines. We did another vignette on COVID, and I won't go through all the details, but it was basically a similar thing where we were presenting a patient who had all of the classic signs and symptoms of COVID-19. And we were asking the clinicians how you would treat them, who would you notify, and those sorts of things. And so this was done in like March and April of 2021. So a ways into the pandemic, but at a point where the DRC had not had a lot of cases, especially in some of the rural areas where we were surveying. But we found, encouragingly, that about 70% of the clinicians could identify COVID as a possible diagnosis. 85% of them said they would transfer a patient with COVID to another facility, which is what they're supposed to do. And nearly everyone said that they would notify a higher level authority, which is also what they're supposed to do. And so this was really encouraging, seeing that, you know, doctors and nurses who may have never seen a real case of COVID, for the most part, knew how to treat it, knew how to handle that case. And so from this, we recognized that the DRC government worked really hard to raise awareness about COVID. But they didn't have a lot of data on how many cases were actually happening, or whether they were getting picked up in surveillance systems. And so the vignette was able to show them that clinicians did have a high level of awareness and knew how to handle a case, even in places that hadn't had very much. So how are vignettes useful? What can they measure? They could be used to assess to what extent guidelines are being followed, maybe after there are new guidelines or after training or during a crisis. They can help you understand what are the most common misdiagnoses, what signs and symptoms are most helpful. You can look at provider attitudes and biases, which we did a lot in that family planning vignette. And you can even do some more analysis to look at determinants of treatment errors. So does education matter? Does training matter? Do the equipment levels in the facility matter? And start to get some of the data that could help you improve quality if you know what its determinants are. Some other ways of measuring quality, I don't have time to go into all the details, but we've done observations of patient care with checklists to see whether providers are doing what they should. We've looked at the paper registers in the facilities to see whether people are getting the different medications and tests that they need. We've looked at vaccines, actually pulled the vaccine vials and looked at the temperature monitoring and the expiration dates to see if they're still good once they're put into an arm. We've done focus groups with patients. We're having health workers right now keep diaries related to quality. And so lots of different kinds of data that you can get creatively, with sometimes relatively low cost to get at the quality of care that's being delivered, even if you don't have the types of systems that other countries might have. So that was measuring, and now I'm going to talk a little bit about an intervention to improve quality that was implemented by IMA World Health, and Tulane was responsible for evaluating it. So this is called a community scorecard. Some of you may be familiar with this, but if not, the idea is that a set of indicators, which are shown here under, I guess, indicator, a set of indicators for measuring quality at a facility are developed. And then there's a very simple rating system from, in this one, like very bad to very good, and then a space for some explanations. And so these are taken to communities and used as a tool for the community to, on their own, assess the quality of health services that they feel they are receiving. So the steps are, first, the community and the health service providers get together for the scorecard exercise. In the DRC, this is usually done twice a year. It can be done at different intervals, but that's how they do it. And then the community members get into groups based on common characteristics. So maybe youth and religious leaders and older men and women with children, however they want to divide themselves up, but they get into these like groups. And then they rate their health systems based on the indicators on the scorecard in their small groups. At the same time, the health workers, so the doctors and the nurses, get together and they assess their own performance based on the scorecard. So everybody's doing it at the same time. And then everyone's brought together in an interface meeting to discuss how they rated each indicator, decide what their priorities are, and then together develop an action plan for improving health services. So it's kind of this collaborative thing among the community and the health workers. This is a conceptual framework for how it's supposed to work. I won't go into too much detail, but you can see that the final outcomes they're trying to achieve are service delivery and quality improved with the goal of utilization increasing. They want more people to actually feel comfortable using the health centers. So we evaluated it using qualitative data collected at 2 points in time. We did interviews and focus groups within 4 communities in the Kasai region where it was being implemented. And so you can see the different types of people that we talked to in these interviews. Results, we were interested in how the community's sense of empowerment changed. And we found that through this intervention, the community members became aware of their responsibility to co-manage health services. In the DRC, this is expected that communities will have a role, but often communities don't feel that, don't feel like they can have the agency to do that. So through this, they gained that sense in a lot of cases. My favorite example was one community sent secret shoppers to the health center to kind of spy on them and see how people were being treated. Here's a quote: "The community scorecard is like a thorn in the toe to wake us up, providers, public, and community members or community leaders." We were also obviously interested in the impacts on service quality and utilization. And we found that the availability of drugs and equipment and especially the physical state of the building improved. Health worker behavior changed. They became more punctual, welcoming, willing to treat people without asking for payment first. And as a result, utilization was reported to have improved, especially for maternal health services. Keep in mind that this was all qualitative. This was all data from interviews. And so we didn't look at this through, numerical data. But in terms of the opinions of the people involved, they did feel that there were these improvements. And here's a quote from health workers explaining that they had changed their working hours to be more accommodating for the schedules of the people they were serving. Communities, however, did report that they had not received responses to the requests that they sent up higher in the health system, particularly to the health zone office. So a lot of times they would fix what they could within the community, but they would have to send requests farther up the chain. And in those cases, none of the people we interviewed had received a formal response from the health zone. So we were lastly interested in the reasons why the scorecard may or may not lead to improvements. And again, we found that improvements occurred in areas where the community and the health workers already had the power to make the change. So things like making physical repairs to the building, repairing a road, changing the way they acted or the hours, like those kinds of things did change through this system. Anything that they needed to go to the government for, though, was sort of radio silence, that they had not been able to kind of pierce that ceiling to get attention from higher up. So we found that this was powerful for improving relationships between communities and health workers, community responsibility, improving their perceptions of the quality of services. It did really seem to work. Their success at reaching the government was not so successful. And I think part of this was because this was implemented by an outside program. It was implemented by an NGO who, in all honesty, probably didn't get the government buy-in that they should have at the beginning. And so there were plenty of people who didn't even know about it in the government. Delia, do you have a comment?
I think you can continue, and then after you're done, we can head on to the questions. So.
Okay, sounds good. I'm almost finished anyway. It's the last couple of slides.
That's fine.
Okay. And then we had suggested, and I'm not sure that they did it, but our suggestion was that instead of each community sending individual requests, it might be more powerful if they organized together and sent requests on behalf of, say, a whole health zone, instead of, kind of popcorn requests up to the health zone. Other ways that we have tried to improve quality are Tulane led a clinical mentoring program where we sent Congolese physicians out into more rural areas, and they really, really closely mentored the people working in those facilities around managing labor and delivery to try to improve maternal mortality rates. And so that's one thing that seemed to work pretty well. Improving pre-service training in general, working with the university to make sure that the people who are graduating and going out and working are well prepared. Improving medicine and equipment supply chains, that's something we're working on right now. Improving supervision, and then this is not happening in the DRC, but I did work on a hospital accreditation program in another country that seems to work really well, sort of setting up quality standards and helping facilities be able to meet them. Was a great tool for improving quality and something that someday I would love to see the DRC do as well. I have to do my funding acknowledgement. So the Vignette work was funded through the Data for Impact mechanism by the US government, by USAID. And then the scorecards were funded by the UK government, by DFID. So thanks to all of them for that support. And that is all my slides. So I'm really happy to take any questions or comments you might have.
Wow. Thank you so much, Janna, for that very intriguing presentation. Sometimes I just feel like I need to hear more and more and more, because when we talk about healthcare, usually the discussion doesn't center around quality. We talk about, do we have it? Is it even functioning? We don't get to talk about how well is it functioning to begin with. I mean, sometimes it depends on the circumstances, because what comes first, do we even have that system? And then before we start talking about it, but this is very enlightening. And where I was stuck most is the part where the community, when you were talking about how the community has the opportunity to assess the kind of programs that they're receiving. Mm-hmm. I don't know about other countries, and it's an interesting discussion that I would love to hear from others from different parts of the world. But I don't think it's in many countries or communities where the local community, the local people get to have a say, not even a say, even to be aware, to be empowered about voicing their concerns or even following up on their concerns, as much as it might not, the response might not be fast or might not be as expected, but at least they know that we can ask, we can present our concerns. That's really, really, to me, very interesting. And the collaboration, what I seem to feel is that the collaboration between NGOs and the government would really be more impactful, because it shouldn't be that these programs are run or promoted by NGOs and the government is not either aware or is not ready to take them up. Because, you know, NGOs, sometimes their work is short-lived. It depends. It might work for a certain while and they leave. So some of these programs, I really think that I feel the government should be able to either take up or support the NGOs in doing for that continuity. But I will talk over and over again, but I have another question that might come later, but thank you so much for that presentation. I see there's Salim's hand up and Delile had her hand up, so I don't know if Mama Langeni still has a question, but we can start with Salim, I believe. Salim,
no, I don't, sorry.
Oh, no problem,
maybe,
thank you.
Maybe I clicked the hand unknowingly.
That's okay, thank you. So Salim.
Yeah, Dr. Wisniewski. That was a nice presentation, and I'm really interested in it because I've done some health policy work actually, in fragile settings. So I was curious. I know you do mention in your abstract that you've looked at a number of. Hello, can you hear me?
Yes.
Yes, that you've looked at a number of tools for measuring quality. Can you hear me?
Yes, go ahead.
Okay.
Sorry, yeah. So I know you've mentioned in your abstract that you've looked at a number of measures for looking at quality in healthcare settings. It looks like the vignette focuses more on health worker readiness to provide the service in terms of skill and training. Have you thought of how you could combine, for example, some of the tools that you mentioned in your abstract to give us a broader overview of health care quality, in terms of service readiness and also the quality of the available services.
Are you asking like how to triangulate all those different like ways of assessing into a
exactly, to give us a broader overview? Or if not, do you consider any of the measures superior to others when it comes to measuring quality?
Yeah, I think my gold standard would probably be, some sort of analysis of the medical records themselves, which is why we did go to the facilities and look at the physical registers to see, were people getting all the things that they needed. But I think your point is well taken, that none of these are perfect and they all kind of measure different pieces of the big quality pie, right? In the beginning, I went through all the different components of quality, and I think some of these tools are better at getting at pieces of that than others. And so I know we're doing an evaluation of USAID's integrated health program in the DRC. So they're strengthening the health system in 9 provinces, and we're writing a report that just keeps growing. Like every few months we add some more, and Francine knows she's working on it. We just keep adding new sections because we have more data trying to get at this story. So I don't think I can easily make an assessment of, thumbs up or thumbs down, the system is good or quality or not. But yeah, in a place like that, especially, or really anywhere, you have to take all the pieces of data you have and try to put them together. I don't know if that answered your question.
No, that does. It definitely does. Maybe, I guess, going forward, one way could be when, the systems are better and you begin to get a sense of what services the people are getting, the patients, and you're able to get an insight into their own evaluation of the quality of services. Maybe you can triangulate that with what you get from the providers and see which one gives a more accurate picture. But this is good work. Thank you.
Thank you.
Yeah.
I was saying, any more questions and comments?
Yeah, I do have a comment. I think this is great work. And I wanted to know, you mentioned about focus groups, like how many people were in your focus groups? And were they like, and I'm asking this for learning purposes, like, were they representative? Like, did you consider people from different regions, or you had just maybe some region that you focused on, like to do your pilot?
Yeah, we do focus groups a lot for a lot of different studies or evaluations or purposes. And so typically I think they probably have between 6 and 12 people in them.
Okay.
There'll be people who have something in common. Like we often do focus groups with caregivers of children under 5, for example,
Okay.
Or maybe it will be women who delivered a baby in the past year, or maybe it will be, nurses who work in the same health center or something like that. But we collect qualitative data in all of the places we work for the most part. So now all of those 9 provinces, I think we've at some point collected qualitative data from them.
Yeah, thank you.
Anyone else? All right, maybe a quick question before we move on to the next presentation. It's just a kind of overall question. As a researcher from another culture, what is your experience doing research in a country or a community that is different from the culture that you grew up and was raised in?
Yeah, that's been really interesting. I think I am very fortunate to have been able to do most of my work in the same country. I know some people who kind of bounce around, maybe they work in Nigeria and they go to Uganda. And I think that it has been helpful for me to keep going back and keep spending time there so I can keep learning. And I think the other piece is that it has been vital for me to work, under the mentorship of people from the Kinshasa school who can help navigate the culture, not only the culture of the people or the systems we're studying, but also just the culture of working there and doing research and how to present and how to get your message across and things like that. That's been really helpful. But it's been Yeah, I've had to learn. I've made mistakes and all of those sorts of things. But I think Congo is a pretty welcoming and forgiving place for those sorts of things. And people have not told me not to come back yet. So I really appreciate that.
They won't. I don't believe they will. All right. Are we closing anyone out? But we can move on. If you have a question at the end, I think we'll have a few more minutes. If something comes to your mind after, you can go ahead and ask. But thank you so much. I'll call you Dr. Janna.
Thank you.
For that very wonderful presentation. So we would like to move on to our next presenter, who is Francine Woods. Yes?
My name is Marva, and I was wondering, does she speak French? I am getting ready to start. I'm going into Congo in Kinshasa, and maybe we can get some information from one of you all later.
Yeah, I do speak French. I'm not great at it, but yeah, French is really helpful to have there. They also speak, Swahili. Although if you're from East Africa, you won't like the Swahili. It's very different. But yeah, and Lingala as well. Yeah.
All right.
Thank you.
Thank you so much.
I have an additional question. Like, I know, you already have that collaboration with Congo, but do you have plans of expanding that to other countries? Because as far as I know, there are many countries that would benefit from that initiative that you have in Congo. So do you have plans of sharing that with other countries as well?
There's no firm plan for that right now, but I would love to. I think especially regionally, for example, the CAR does not, as far as I know, does not have a school of public health. And so, but are very culturally similar and linguistically similar. And so I think there could be some synergies there, or with, the little Congo with Brazzaville, or maybe Gabon. I could see some sort of regional collaboration to bring some of the lessons we learn in the big DRC to everywhere else. But no firm plans, but that's, yeah, I would love to do that.
All right.
Thank you.
Thank you all for those questions and comments. And we are moving on now. Francine, you can take the floor.
Thank you very much. And thank you for having me here to share my work. So I'm going to share my screen and make sure I do this right.
It's not shared yet. Yeah, it is.
Okay, so can you see it?
Yes, we can see it, but it's kind of blank. Oh yeah, definitely, yes.
Perfect. And so today I'll be talking a little bit about male involvement in maternal and child health, specifically in Kinshasa, DRC, and it's the focus of my dissertation. So over the years, the maternal mortality ratio, as well as the infant mortality rate, has decreased significantly, but it still remains a public health concern. And reducing these high rates was one of the yardsticks for the Millennium Development Goal, and is currently a yardstick for the Sustainable Development Goal. And these are indicators that measure the development of nations. And so the high rates of mortality are caused by several factors, one of which is lack of access to healthcare. And in many developing countries, including the DRC, men are key decision makers and providers, and they often determine a woman's access to economic resources and healthcare. So consequently, there has been a huge interest in involving men in health, and these strategies have been employed to support a woman's access to care, address the influence of gender inequality on maternal and neonatal health, as well as promote men's positive involvement as partners and fathers. And so these involvement strategies primarily support a woman's care seeking and decision making for her own health and the health of her children. And it's important to note that as much as male involvement is good, it can also be bad. And so in the sense where you don't want to reinforce gendered stereotypes of men as decision makers and reduce a woman's autonomy. So in doing this research or in programs that try and involve men, they need to be careful of this unintended consequence. And so what is male involvement? So unfortunately, there is no universal decision for male involvement, and researchers haven't agreed on which dimensions are important. It's been defined differently depending on the context as well as the location. Nevertheless, it's been agreed that male involvement is a multifaceted and evolving construct, and the conceptualization has evolved from a one-dimensional construct that some look at just like attendance to, let's say, an instance ANC, attendance at ANC, or attendance or presence at delivery, to a more multi-dimensional construct, emphasizing the different aspects in which a man can be involved. So looking at a physical, economic, social, and emotional capacity. So for male involvement in pregnancy, the Commission on Paternal Involvement in Pregnancy Outcomes defines it as activities or practices by the male partner and a couple anticipating birth that ideally leads to an optimal pregnancy outcome. And for child care, Lamb and his colleagues suggest that it's made up of 3 different dimensions. So engagement, accessibility, and responsibility. And engagement is the direct contact and shared interactions with the child. And accessibility is the presence and accessibility to the child, and responsibility is arranging for resources to be available to the child. And so male involvement is important for various reasons. For the mother, fathers involved contribute to reducing maternal stress during pregnancy, the risk of postpartum depression, among other things. It can also increase the use of health services. One study found out that a woman who attended ANC with her partners were more likely to deliver at a facility as well as return for postnatal visits compared to women who attended antenatal care visits alone. Infants with involved fathers have better cognitive functions and more frequently develop into children with high self-esteem who can resolve conflicts without violence. And for fathers themselves, those involved in their children's lives have been found to be more satisfied, more likely to stay involved. They've been found to have better health. And some studies show that fathers involved in caregiving have more satisfying relationship with their partners, feel more connected to their families, and report better sex lives with their partner. And so within sub-Saharan Africa, how involved are men? The levels vary, as we can see from the slide, and it's been measured very differently depending on the context. So it's been measured in ANC, delivery, postpartum care, postnatal care, birth preparedness, complication readiness, prevention of mother-to-child transmission of HIV, as well as family planning. So taking antenatal care as an example, you'll notice that the range is from 7 to 65. So in spite of this large range, which occurs for multiple domains in which men have been involved, most of the studies indicate that involvement was on the lower end of the range. And so, as I said previously, measuring of male involvement has gone from a binary or one-dimensional construct to a multiple dimensional construct. And so, again, using ANC as an example, most measures that have looked at male involvement in ANC have used this binary construct. So whether you're looking at measuring the man's presence at antenatal care or whether he accompanied his wife to ANC. And more recently, there have been more complex measures, and most of them have been in the form of index measures that have either come up with an additive score or averaging the number of activities that men have been involved. So this is an example of a study that looked at involvement in ANC. And so they created an index measure looking at whether or not the man accompanied his wife to antenatal care, whether they knew of the antenatal care visits, whether they provided financial support to the partner to attend antenatal care, whether there was discussion on informational interventions given at the ANC with the partner, whether they asked the partner if he could use a condom, And this questionnaire was asked to the females, the women, and not to the men. And then lastly, whether they take their time to find out what goes on in antenatal care. And a lot of studies have asked both men and women. There hasn't been a consistent thing of whether they only ask men or ask women, but they usually ask either or. And so for childcare, there have been very few studies, and most of them have focused on involvement in child health services, specifically immunization, and less on home-based childcare. And studies have measured activities including providing financial support for child's routine immunization visits, whether or not they accompany the partner to the routine childcare immunization visit, whether they had discussions, whether they share decisions with a partner to have child routinely immunized, or whether they took the child to the routine immunization alone. And studies that have reported involvement in child care have been mainly conducted by UNICEF in their multiple indicator cluster survey. And so the survey results indicate that about 3 to 11% of fathers participated in 4 or more learning and readiness activities, which included reading books, telling stories, singing songs, playing, taking the child outside the home, naming, counting, or drawing things with the child. And the children they ask about are between 24 months to 59 years old. Several factors are associated with involvement during pregnancy and in childcare. And so these include social demographic factors, sociological, health services, related factors, as well as policy, family or social support, ownership of the unborn child, and the quality of the relationship with a partner. So in spite of all these multiple factors, most studies suggest that the low levels of involvement is because pregnancy and childbearing, as well as child care, are considered female domains. And so this perception of gender roles is reinforced by community perceptions, societal and cultural norms regarding health and gender roles. So in some of the studies that have looked at male involvement, various frameworks have been used to understand what determinants influence involvement. And so this is just an example of one, and it's the Responsible Fathering Framework. And it was developed in 1998 by Doherty and his colleagues. And they're postulating that fathering is influenced, or in particular, paternal involvement is influenced by several factors, including father factors, co-parental relationship factors, contextual factors, child factors, as well as mother factors. And many of these factors that we are seeing on this framework, or in this framework, we saw in the previous slides that when we talked about the determinants of involvement. Regarding strategies that have been used to promote men's participation in maternal, child, and women's health, they've varied, and there's not really been consistent across studies. So some studies have used community dialogue and social mobilization. Some have created and strengthened and used male peer leaders to improve involvement. There have been facility incentives such as a shorter waiting time. They have altered clinic hours to facilitate access by men or for men. And they've also created family support groups. And so I want to spend a little bit of time talking about involvement within the context of DRC. So DRC has high rates of maternal and infant mortality compared to the rest of the world. And the country's social indicators are unfortunately one of the poorest in the world. According to the 2019 Human Development Index, the country ranks 179 out of 187 countries globally. And this ranking is based on poor overall health, gender, and overall poverty status in the country. Statistics also indicate that the gender inequality is high in the DRC. So the Gender Gap Report, which measures the differences between men and women across 4 dimensions of health, 4 dimensions of health, education, economy, and politics, So according to the 2020 reports, the DRC ranks 149 out of 153. And it's compared to the other countries in sub-Saharan Africa, it was last. And regarding the levels of involvement, it's low in the country. So involvement in pregnancy has been measured by 2 HIV studies. The first study is a randomized controlled trial that found that 22% of male partners of pregnant women invited to HIV testing and counseling actually attended. And then the second study found that only 7% of male partners participated in pregnancy-related activities after the intervention. And regarding childcare activities, the mixed survey by UNICEF that I mentioned previously reported that only about 7% of fathers participated in 4 or more learning and readiness activities for their child. And so some of these gaps, these are some of the gaps to research on involvement, and they include the lack of consensus on the definition of male involvement. There is limited research from developing countries, especially in the DRC, and there's little known about male involvement during pregnancy and childcare in the DRC overall. And a lot of the research has been conducted in sub-Saharan Africa, has been conducted within HIV research, which doing research on HIV, there are other things that these men have to deal with in addition, other determinants that influence their decision versus if you're not HIV positive, have a partner who has HIV. And then also another challenge is the unintended consequence of potentially disenfranchising the mother or the woman, as well as reducing her empowerment in encouraging men to be involved. And so I want to shift focus a little bit and just share some of the work I am currently working on, and it's part of my dissertation research. And so to answer the question, how involved men are in the DRC, I'm going to be talking about the Momentum Project, which is one of the many projects that Tulane has in the DRC. And so this is funded by Bill and Melinda Gates, and it's a gender transformative family planning, maternal and newborn health and nutrition intervention project in Kinshasa. And the target audience is male partners, the first-time mothers, as well as key influencers of first-time mothers. And as part of the intervention, nursing students visited these first-time mothers, provided home visits, organized community dialogues with the first-time mothers and their male partners, and also with the key influencers, and then had group education sessions for first-time mothers and male partners. And so for my current research, I'm primarily using the baseline survey from Momentum. And so I have the cross-sectional secondary data, and I'm focusing on the male partners of the first-time mothers. We recruited and interviewed 1,766 at baseline, and it was conducted in 2018. Data was collected from 6 study health zones. It was pre-tested. The survey was pre-tested and administered using a smartphone. And so to be included in the study, male partners had to be willing and competent to provide consent, able to speak French or Lingala. They had to permanently reside in one of the study health zone, and they had to be a partner or husband of a recruited first-time mother who was between the ages of 15 to 24. Nulliparous basically means she didn't have any children at the time of the survey and was 6 months pregnant at baseline. In the analysis, I used factor analysis, both exploratory and confirmatory factor analysis, conducted descriptive and bivariate analysis, conducted multivariate regression analysis, which is linear regression in particular. And the analysis adjusted for control variables. I'm not presenting all my data, but I conducted some moderation and mediation analysis because of some of the questions I was trying to answer. Multicollinearity was assessed with a variance inflation factor less than 4, and that indicated that multicollinearity wasn't a problem. And all the analysis was conducted in Stata. And so because this was measured at baseline, we didn't have data on if the men were currently involved. They were currently, so we measured the closest thing we could get, which was their willingness, so the intention to be involved. And we asked them about their willingness to be involved in 16 different routine childcare activities. And these activities came from either the program M manual developed by UNICEF, developed by the WHO. And this manual was what was used to develop the curriculum that was used in the group education sessions for the male partners, as well as the Who Does What questionnaire. And so male partners were asked about their willingness to participate in routine childcare activities. In my analysis, I coded those who were extremely willing as 1 and all others as 0, primarily because previous research has shown that those who are very willing to be involved are those who actually perform the behavior. And so I wanted to get an idea of what factors were associated with those who would actually perform the behavior. And the 16 activities were divided into 2 categories based on Lamb's definition that I mentioned earlier. And so they fell into caregiving responsibilities, which he called responsibilities. And the other category was interactive activities, which Lamb called engagement. And basically I created a score by summing all the things in all the different activities. And so I had a continuous outcome. And the higher the score, the more willing the man was to participate in these routine childcare activities for caregiving responsibilities and for interactive activities. And another outcome that I looked at was involvement during pregnancy. Because this was conducted at baseline, it was before birth. It was when the mother was 6 months pregnant. We asked them about their involvement in 11 activities up until that point. I used factor analysis to identify the different constructs that were present in this overall score to see if it could be further divided. And so items that had a loading of less than 0.3 or a negative were dropped, and factors that had an eigenvalue greater than 1 were retained. And so after my analysis, I ended up with 2 factors which had eigenvalues greater than 1. And based on the items within each of these factors, I came up with 2 different categories of involvement during pregnancy, which is involvement in antenatal care or birth preparedness, or involvement in shared decisions. And so you'll notice that one of the first one is in bold, not highlighted. And this is partially because that was dropped from the analysis because it had a loading less than 0.3. So after my analysis, I only had 7 items under the involvement in antenatal care and birth preparedness. And so overall, looking at the individual activities, male involvement in pregnancy was low, and less than 50% wanted to be involved, or not wanted, they were involved in any activity. Most were finding a donor or finding a blood donor was the lowest or least common activity men were involved in. And saving money for emergencies was the most common activity they were involved in. Overall, they were involved in an average of 2 antenatal care and birth preparedness activities, which is out of 7, and involved in about 1 shared decision with the first-time mother. So moving on to the willingness to be involved in child care, it ranged from 33% to 73% for any of the activities. The men were least willing to clean the house, and in more of the household or cleaning or cooking aspects of household activities or caregiving responsibilities, and they were most willing to take the baby to the doctor. Overall, 17% were willing to participate in all 11 caregiving activities, and about half were willing to participate in 5 interactive activities, all 5 interactive activities. And so for the sake of time, I'm going to now zone into just the involvement in childcare in the DRC, and look at one of the questions I was trying to answer, which is what factors are important for male partners who are willing to be involved in the DRC, in childcare in the DRC. And so to help with this analysis, I looked at different factors from the Responsible Fathering Framework, the Theory of Social Norms by Bisheri, Integrated Behavioral Model, and previous research that were available in the Momentum survey, the baseline survey, and developed this conceptual framework. And so I'm postulating that attitudes towards gender equitable norms, beliefs about paternal involvement, perceived norms towards paternal involvement, personal agency, co-parental relationship factors would influence a male partner's willingness to be involved in routine childcare activities. And so for attitude towards gender equitable norms, it was assessed using the gender equity scale, MENS scale. For beliefs about paternal involvement, we asked male partners about their personal belief as well as their perceived community belief about paternal involvement. For perceived norms towards paternal involvement, we asked them about their descriptive norms, injunctive norms, normative expectations. For personal agency, we asked them about their self-efficacy and autonomy. For co-parental relationship factors, we asked them about relationship satisfaction, whether or not they perpetrated intimate partner violence, and their involvement in pregnancy, during pregnancy, which I talked about previously. And so just jumping into the results. So these were my findings after my regression analysis. And so looking first at the perceived norms and just focusing on the significant factors. So you'll notice that in the first column, we have interactive activities. And so for perceived norms, normative expectations, descriptive norms, so those who had believed that more than half of their fathers in the community performed routine childcare activities were more willing to participate in routine childcare activities compared to those who believe that less than half of the fathers in the community performed routine childcare activities. And injunctive norms was also significant. Whereas for the caregiving responsibilities, only our normative expectations and descriptive norms were significant. These two were significant. So moving on to personal belief, which is our green box. So for interactive activities, those who believe that 2 or more activities were extremely appropriate, who had the personal belief that 2 or more activities were extremely appropriate, were more willing to be involved compared to those who didn't believe any of the activities were appropriate. For caregiving activities, those who believe that 1 or more were extremely appropriate were more willing. And then moving on to perceived community belief, I only found significance for caregiving activities, and in particular, those who had the belief that 2 or more activities were extremely appropriate was significant. So moving on to the other factors, co-parental relationship factors, all of them were significant, not all in the direction I was expecting. So first looking at past year intimate partner violence. For both interactive activities and caregiving activities, there's this positive association. So those who perpetrated intimate partner violence were more willing. And then for involvement in antenatal care, there's a negative relationship for both, again. And in this case, those who were involved were less willing who were involved during pregnancy were less willing to be involved in childcare. And then for shared decisions and relationship satisfaction, you see this positive relationship where those who made, with each unit increase in the number of decisions, shared decisions, the male partners were more willing. And then with each unit increase in their relationship satisfaction score, they were more willing to participate in routine childcare activities. And then lastly, self-efficacy also had a positive relationship. And so from these findings, it tells us that willingness varies depending on the activity. It's greater for interactive activities as compared to caregiving activities. And overall, these findings are similar to other studies, with the exception of the mixed study. So if you remember, for mixed, they range from 3 to 7%. Whereas in this analysis, I have over half of the male partners being willing to be involved. With that said, I acknowledge that I am looking at willingness, but most of these studies that I'm comparing it to are looking at actual involvement. But overall, there was some similarity across, with the exception of the mixed levels of involvement. And it's partially because I looked at, the study measured involvements for children on 12 years or younger, and mixed looked at an older group, so 24 months to 59 months. And some studies suggest that for interactive activities in particular, involvement decreases as the child gets older. So the findings are in accordance with social norms theory and other research done in other areas of health, not necessarily in child care, and that the positive perceived norms is associated with willingness, was associated with actually performing a behavior. Similarly, research has also shown that positive perceived beliefs are associated with behavior, which is similar to what I found, that positive beliefs about childcare was associated with willingness. So relationship satisfaction, perceived self-efficacy, and involvement in shared decisions was also associated with willingness. And so moving on to the two results that I wasn't expecting. So past year IPV perpetrators were more willing to be involved. And this is contrary to previous research. And I wonder if it's partially because of this whole idea of power and control. So it's possible, although I can't conclude because I'm using cross-sectional data and it's not longitudinal, it's very possible that men who are willing may be doing so to reduce a woman's reliance on others in her community. So whether it's her friends or whether it's her family, and in doing that, you're isolating her further. And I think this surprising result warrants future research and possibly looking at how controlling behaviors, what part it plays in involvement, and really understanding that. And in answering this question, it's important for the question, or whether it's a survey, whether it's a qualitative approach, to look at controlling behaviors pertaining within the context of childcare. And then another surprising result was that involvement in antenatal care and birth preparedness reduces willingness. And so we know that from previous research that health, childcare, women's health is considered a woman's domain. And so some men in other countries have been, and research has shown men in other countries have faced sanctions as a result of being involved, whether they've been ridiculed, whether they've been called weak, and so on and so forth, because they are participating in this female domain. And so it's possible that the spaces in which they were involved, whether it's in the hospital, whether it's at home, may not have been inclusive. And so this may have affected their experience. So they might either have had a positive or a negative experience. And so I think it's important to really understand this and look at any research, to look at environmental factors as well when you're measuring their involvement, especially if you're using more of a longitudinal approach where you're, in this case, measuring involvement in pregnancy and then measuring involvement in childcare, because these factors may affect their willingness and actual involvement later on, as well as looking at their satisfaction with pregnancy. And so these findings may be helpful for programs. It tells us that the decisions of fathers to participate in either form of activity, whether interactive or caregiving responsibilities, is an intricate process influenced by several factors, and programs should aim to address several of these factors in their strategies. Strategies adopted should promote positive perceived norms and beliefs about engagement. At the same time, programs should be wary of unintended consequences, one of which I talked about previously, which is disenfranchising a woman or reducing her autonomy, because in the way we're trying to increase men's involvement in health, we're not trying to reperpetrate these gender norms that are already in effect. And also be mindful of something that is called the boomerang effect. The research isn't conclusive, but the idea is that if you are focusing on one particular thing, so example, you're trying to change the perception of the number of men who are involved in the community, so you just have messaging, you may have short-term change, but in the long term, your men may not be involved because you're not addressing other aspects of that influence involvement, so such as the environmental factors. And so you want to be mindful and at the same time use multiple strategies as much as you can to be able to get this behavior change that is trying to be achieved. But yeah, this is all I have. I cannot go on without acknowledging my mentors, my committee members who have been an integral part of this research that I've been doing, and also in particular, Dr. Gage and Dr. Bertrand, who Dr. Jane Bertrand is the PI of Momentum, and Dr. Anastasia Gage is a co-PI as well as a technical director. And so I've been working with them closely and have given me access to this data. Thank you. That is all I have for now.
Wow. Wonderful. Very wonderful research for sure, given the context, given the culture, given everything. Because when we were discussing about your presentation, I mean, I definitely knew it was going to be fascinating because of the experiences, I would say personal experiences growing up in a similar culture where you don't see men getting involved often, I would say. And before the presentation, when somebody talks about male involvement in maternal health, you always think it's a good thing. I mean, the obvious analysis on the face value is that, sure, that's a great thing, or it's important, or it's long overdue. But then when you're presenting and we're talking about unintended consequences, the motivation behind getting involved, the negative effects that might come up as a result of that, I just think that are really very important to note or to understand for people going into this research, not only going into the research, but trying to, in overall, understand the service delivery in different countries. So thank you so much. I mean, it's really fascinating, and I was looking forward to both talks for sure. So I wanted to ask, I don't know if the database that you are using enabled you to analyze this, but do you think there are variations in terms of urban and rural populations, in terms of engagement and involvement? Are you able to kind of tell whether male in the rural areas or in the urban areas will be more engaged or not? Just kind of.
So we didn't look at involvement in rural urban, but we looked at within different zones. And I'm pulling up, I actually have it right here, so I can answer that question for you because I don't know it's off the top of my head.
That's okay.
Give me 1 second. So overall, it's relatively similar. There really isn't that much difference. So for example, in Messina 1, health zone had the highest level. So for interactive activities, male were willing to participate in about 3 activities compared to Bumbu, which they had 2.9. So there really isn't that much of a difference across. We didn't categorize any of these as urban or rural, so I wouldn't be able to answer that question in much detail. With that said, I wouldn't be surprised if there is a difference, partially because I feel from my research, and actually other studies have found that involvement is lower in more rural areas because you have the notion of women and health being a woman's domain is more areas compared to more urban areas. And so I would say that that is the case, but we're not able to tell that in momentum per se. The one thing I could do is like take a step back and try and categorize these different health zones into urban versus rural, but it's also going to be hard because within each health zone, there are it's not really a rural or urban area, but it's a mix of that within each health zone. But I can go back and try and see if that is possible. But I think it will be an interesting question to be able to answer.
That's wonderful. I asked because, sometimes empowerment and these other things are factors that are influenced by many things. Could be education, could be, economic power, when women have more economic power. So many of those, but it might not be the scope of your study, perhaps, but if it's possible, that would be really one thing to be able to respond to. And I also thought of, when you were discussing, I thought of the fact that nowadays, I mean, in the recent maybe 20 or less years, when women attend these antenatal clinics, they're required kind of to bring their spouses, especially remember the era of HIV/AIDS in some countries. It's kind of a mandate that bring your spouse before we give you the services or provide you the services. So I wonder, it's not a question, I'm just saying, I wonder whether this would be part of the motivation, or even the process, the inspiration, not necessarily inspiration, but that would be a reason why men may have to be involved, whether they wanted to or not, because if your spouse goes to the hospital and they can be served unless they come with their spouses, what choice do you have?
So I will say some countries have used that approach, or some studies use that approach, but and in most of those cases, they stop primarily because of the negative effects it was having. So because men were, to reduce their wait time, they would see the male partners who came with their
So sorry, my computer went off. I forgot to put it to continue charging. So sorry about that.
But I don't know if you heard the remainder. I don't know the last thing you heard.
You were talking about some studies, the approach, some studies that have given that approach. So I then didn't know what happens to those studies.
So in some of these studies, they've just found out that it has a negative consequence. So some cases, women were paying men to pretend to be their partners just so they could be seen early and to leave. And so it's been discouraged to use that approach of a mandate, even though, yes, some people to get behavior change in a lot of cases need to mandate it for it to happen. but you want them to actually come with their partners and not for some, I guess in some men we're making income out of it. And so it's encouraged to have more of an organic approach where the man actually makes that decision rather than forcing him to come.
Yeah, definitely. I mean, it's an approach, but I wouldn't think it's the best. But anyway, it depends on where you are, if that has to be the case, but these decisions are very hard. So I'll give this opportunity to Salim to ask a question. I saw your hand up first.
Oh, thank you, Damaris. Thank you to the presenter, Francine, right? Yeah. So I had a question about the socioeconomic factors that Damaris mentioned, and I guess it's a suggestion. So it has policy implications. If you are finding that educated men or working men, are less likely to be involved, then there's a policy implication there, right? How do you encourage participation among such subgroups? The other thing is the unexpected result you had on IPV, men who were previously engaged in intimate partner violence. Have you considered whether this could be because some intervention occurred after the episode of violence? Can that be a possible explanation? I'm just curious. That these men receive some counseling, from family members or from the church or community religious organization, which change their perspective on participation.
That is a very good point. And I will say, first of all, thank you. And that is a very good point. I didn't think about that. It's very possible, but unfortunately, it's not something that we measured. So there's no way to test or to determine whether or not, like to control for it. But I think going forward, I think it's important to also measure that because it can affect it. And going back to your first question about these different subgroups, whether education or socioeconomic status. So in the analysis, I didn't show it, but educational level was important. So men with a secondary or higher education were more willing to be involved, whereas socioeconomic status wasn't important. I think for program and policy implications, I think it's important because at the end of the day, we still have the issue of gender inequality and just this perception. And so personally, I think it's if we're able to change those attitudes towards gender equity, where men don't perceive pregnancy or women's health as a woman's domain, we will probably have more success. With that said, it's also very hard to do. Changing someone's attitude is a long-term investment, which I know a lot of programs don't have funding for. So it's something I'm still trying to figure out. Policy level, I don't know what you're going to change to be able to change attitude. But I think from just based on research, changing that, it's very important and could see some result in change across all levels of socioeconomic status.
Oh, that's really true. And like Damaris said, it's also maybe beyond the scope of your project. So completely understand. The other one is just a little bit technical, but just a suggestion. So I know you presented the estimates on what you thought could explain their willingness to participate. And I was curious whether the estimates are just the odds ratio or the actual probabilities. In other words, we can tell from the table that men who have certain beliefs or believe in certain norms are more or less likely, right? But we can also go further and say maybe they are 20% more likely or 30% more likely. And I think that is also significant for policy, right? If we want to increase the participation rate by 50%, what should we be looking at changing? And getting those probabilities can help us develop a policy that is specific. So that's more like a technical suggestion. If you are, interested, we can talk more about it later. But I thought I should just mention. Thank you.
And I'll definitely love to connect on that.
Thank you.
Salim, would you be happy to drop your email on the chat?
Sure. Yeah.
Yeah, thank you. Thank you so much. So, Jan, I see your hand up.
Yeah, I was just wondering what your sense is, and this might be beyond your data, but how much does the woman's willingness to have the man involved affect his willingness to be involved? Like, I imagine if I were having a baby, my husband would come to anything I told him to, but wouldn't insist. I feel like it's, within the relationship, it can matter a lot.
So unfortunately, we didn't measure that. And that's one of those things where hindsight, like we wish we had collected this, we wish we had included it. I want to say it was part, but we had to cut it out just because of how big or long the survey was. But I think it's an important thing because a lot of times research has also shown that at times a barrier to involvement is the woman, because she wants, this may be an area that she has sole autonomy over or sole control over. And so she may dissuade the male partner from being involved in different aspects. So, but yeah, research has shown that it is something that is important, but we are not able to tell that in momentum, unfortunately.
I know, and it would be more true in relationships where in the background there's a behavior of controlling. So you never get to understand whether this is a positive involvement. Are we still continuing from our personal behaviors? Sometimes it will be like a touchy line too sometimes. That's a good question. All right, I see Florence. Please unmute yourself.
Yeah, so I wanted to first say great job on doing that. Of course, when I saw that topic, I was really curious. Before starting school, I was working in the Georgia Department of Public Health, and they do have a fatherhood initiative. And it was basically targeting, I think they started as a pilot just for the Metro Atlanta before they expanded it to other centers. And it is housed, I think, in the home visiting program. And the home visiting program also kind of helps out with the initiatives of maternal and child health. So I wanted to know, I know you're doing this for your PhD. Is there anything established in Congo, to engage fathers, training them? Because I know what they do in Georgia, what even other states do, they have a curriculum. And then, and of course, being the US, they even have, they do have I won't call them conferences, but they had what they called summits, before COVID, where different men would meet, encourage each other. And there was that peer-to-peer support as well. So I wasn't sure whether there is anything in the African setting for continuity of the work that you are doing, or you just did it for your PhD and that was it?
I think that's a very good question. To my knowledge, I don't think there's anything. With that said, one of the aims of the Momentum project was to ensure that obviously we want it to be sustainable. And one of the parts of it that I didn't mention was this institutionalization aspect of it. And so we had nursing students be the ones who implemented the project. And the use of nursing students came from another study that found out using this whole task shifting approach nursing students increase the access to and use of family planning services in specific, I think specifically implants. And so Momentum tried to build on that. And one of the things we wanted to do was just to make sure that it continues. And so I think, and Janna, please correct me if I'm wrong, but I think for that study, they institutionalized it into the nursing students' curriculum. The idea of them going into, as part of the activities, going into the field and providing family planning to the community members. So something that Momentum is also trying to do is using a similar approach. And so with the curriculum that we use to train the nursing students, currently we're trying to institutionalize it where it's part of it is incorporated into the nursing students curriculum for the entire country. And so no, we don't have anything specifically for male involvement, but the hope is that it's possible that from this institutionalization, nursing students may still be doing these home visits. They may still be doing these group education sessions that will address these different things and hopefully encourage male partners to be involved, as well as work to improve access to maternal and child health services. So to my knowledge, that's the only thing that is going on just to encourage the longevity of this project.
Thank you.
Oh, thank you so much for that. Any more last questions, comments before we close? All right. It looks like everybody's good, and I want to thank you both again, Dr. Janna and Francine. We want to thank you so very much for sparing your time to lead this discussion. It's very important because these are things that are ongoing, improving healthcare and male involvement. I mean, these are things that would not be outdated because it's a process that keeps continuing. Quality, why can't we measure quality, really? But as I said, we usually don't pay much attention into. If we do, then we don't speak about it enough. We don't talk about, are we measuring the quality of the services? Not even in healthcare, in any other fields. We usually really neglect the part of quality. Quantity is what we usually think about. How many hospitals, how many doctors do we have there? How many of these do we have there? But are the services being delivered? It's a question that I don't know if we neglect or we forget, or it's happening, but we don't get to research and speak about it. So it's very important. And there's so much to learn from your discussion. This session is recorded. And if you have friends, students, anybody that you think would have loved to be here but missed because of either the time, especially our colleagues from Africa, you'll be able to share. Once this is ready, I'll share it with everyone here so that the link, YouTube link, so that you're able to share with anyone that you think would benefit from this discussion. So I again want to thank the presenters so much. Thank you to all of you that have stayed until the end. Next week, we're going, not next week, in 2 weeks, that's February 17th, we're having another discussion that is very different. It's going to be focused on Ethiopia, and the discussion is it's about the food security, food packaging. You know how in Africa we're so blessed with a lot of resources, including food, but it does happen that sometimes because of not poor packaging or just less paying less attention to how we package it to preserve it for future use, affected the food security, you know. So we're going to have a discussion from one of our graduate students here, and it's going to, as I said, focus on Ethiopia. I welcome you back if you have an opportunity. We'll share the flyers. If you know somebody that would be interested in that kind of discussion, please share with them, and also welcome that. We keep learning about these things as we find time whenever we are available. So thanks again, everybody, and I look forward to connecting with you more and seeing you in our events if possible. Thank you so much.
Thank you.
Thank you.
All right. Bye-bye.
Thank you.
Thank you too.